I promise to leave you alone after this. So this is sort of the cleanup session for GI. So again, the information that we'll go over is statistically, most likely having to do with what you're going to see on the test. So let's get started. All right, so we're going to do GI Jeopardy. I used to have like the introduction from one of the other doctors that he could sound like the guy on Jeopardy. This is Jeopardy. It's really intense. The categories we're going to go over today, vitamins and minerals, GI malformations, name that bleed, when the movement needs improvement, and then GI potpourri. All right, vitamins and minerals for 100. Name the most common hematologic abnormality that would result from exclusively feeding an infant goat's milk. Is it a folate deficiency anemia, iron deficiency anemia, B12 deficiency anemia, thrombocytosis, or neutropenia? It's one of those things in life you just have to memorize. Okay, good job. So for whatever reason, goat milk is folic acid deficient. So you end up with a folic acid or folate deficiency anemia. Human milk, cows, all your infant formulas, they have plenty of folic acid in them. But if you have a baby that comes in, and it's not an uncommon thing because goat's milk is readily available in all your major grocery store chains. A lot of grandparents still swear by they raise their kids on goat's milk, and so they pass it down. And so if you find that the primary source of nutrition is goat's milk for an infant, make sure they see a dietitian, but recommend immediate folic acid supplementation. All right, strict vegetarian diet, excluding dairy and eggs for a young child, is most likely to lead to a deficiency of what? Is it vitamin C, vitamin E, B1, vitamin D, or vitamin B12. So strict vegetarian diet leads to, it's one of those things you just have to know. You can't walk into your board without knowing this. Good job. So B12 deficiency. So let's just go over this briefly. So vegetarian diet. So those who consume eggs are considered ovo-vegetarians. Those who consume milk are lacto-vegetarians. Those who consume both are lacto-ovo-vegetarians. And those that consume neither are considered vegans. And usually the parent will walk in and tell you, what diet they're on and how they identify. But a diet of a vegan without milk or eggs contains almost no vitamin B12. And you need to ask the question if a mother is breastfeeding and the mother's vegan, and if she is not on prenatal vitamins, she has to be given a supplemental vitamin B12 to prevent methylmalonic acidemia in the baby. So a board question might read that a baby comes in and the baby is developmentally delayed and hypotonic, and the mother is a vegan, and then they may ask you the question that way, what's lacking? So you have to know that vitamin B12 deficiency or cobalamin deficiency leads to big problems. So vitamin B12 is a very important part of mitochondrial metabolism of your branched chain fatty acid, or branched chain, amino acid. So without it, you can end up with methylmalonic acidemia. So initially, again, baby would be developmentally delayed, maybe hypotonic, but then seizures, coma, and death can follow. And it has been known to walk in the door into practices and been known to be on the board. So just be aware of that and how to prevent B12 deficiency. So always ask your breastfeeding mothers, are you on any dietary restrictions? And encourage them to continue their prenatal vitamins. All right, vitamins and minerals for 500. So vitamin B12 deficiency is most likely to occur in a child's status post which surgery? Is it a gastrojejunostomy, resection of the jejunum, resection of the ileum, a colectomy, or a colostomy? So basically, what area absorbs vitamin B12 in the body? Good job. So it's the ileum. So they're going to give you a scenario where someone's had an extensive resection of the ileum and lost a large portion, or they'll give you a patient maybe with Crohn's disease with significant ileal disease to get at the question, what vitamin needs supplemented or what deficiency are you looking at? Good job. All right, so vitamins and minerals for 1,000. A 3-year-old status post-Kasai at 12 weeks. So Dr. Hupert spent time talking to you about this. You know that 60 days or younger is the point at which you want the Kasai to have occurred for the diagnosis of biliary atresia. But this patient's coming in with 12 weeks. The Kasai was performed late. So while it's still possibly beneficial, your mind should already, when reading the question, say, uh-oh, Kasai may not have worked. So comes in, presents with irritability, pruritus, clumsiness. The child's not gained weight for 8 months. On exam, the child has a wide-based gait, hepatosplenomegaly, and diminished deep tendon reflexes. Which nutrient deficiency is most likely responsible? So be sure you read all the question and start thinking like the person writing it. They're not trying to fool you, in all honesty. They're really trying to get at an important, are you going to recognize a fat-soluble vitamin deficiency in this baby? So what do you think? Good job. You guys did. So this is a classic presentation for vitamin E deficiency. So you get the scenario that was described. So vitamin E is present in milk, widely distributed in the average diet, but supplementation is required in just a few conditions. So again, anytime that you would get a fat malabsorption scenario, so biliary atresia that was operated on late and has liver failure, cirrhosis, any patients with CF or pancreatic insufficiency may require supplementation, and short bowel syndrome. So on a board, again, they're going to give you a scenario that's classic for fat-soluble vitamin malabsorption, and then give you a scenario like that. And then preterm infants can have poor E absorption, but I don't think they'll expect you to know that. But when it does present, it gives you the wide-based gait and reflexes as described. All right, so these are 2 other things that you need to just memorize and know. So a baby with a scaling rash in the perioral or perianal area, they may just show you the pictures. Always think zinc. So if it's a periorificial rash, think acrodermatitis enteropathica or zinc deficiency. Another one that's very common for nutrients is a patient on prolonged TPN or a patient with excessive ileostomy output with signs and symptoms of cardiomyopathy. Go right to selenium deficiency in your mind. And the scenario is the prolonged TPN and someone forgot to put the micronutrients into the TPN. All right, so GI malformations for 100. You're called to the nursery to evaluate a term newborn with bilious emesis shortly after delivery. The pregnancy was complicated by polyhydramnios, meconium staining reported at delivery. The physical features are suggestive of trisomy 21 in this patient. The newborn's abdomen is soft, non-distended. What is your most likely diagnosis? Do you think it's A, pyloric stenosis, B, midgut volvulus, C, Hirschsprung's, D, ileal duplication, or E, duodenal atresia? Wow, good job. You guys got this. Yeah, so you gotta know this one. So this is a classic case of duodenal atresia where you see that double bubble appearance if you get the x-ray. So classic findings, the baby's gonna have bilious vomiting at the time of birth, no or mild abdominal distension. The bilious emesis just means that the obstruction is just south of the ampulla levator, so you're looking for something that's a duodenal obstruction. Presentation, there's oftentimes a history of polyhydramnios. Bile staining amniotic flow can be confused with meconium staining, so that's where sometimes they'll overlap and be just a little tricky. But they may pass meconium consisting of intestinal secretions. It doesn't mean they're not going to pass meconium. Bilious emesis occurs shortly after the very first feed's initiated. It's not like it occurs at day 2 or day 3. It is from birth. And then you've got that classic double bubble in the x-ray, and there's basically a gasless abdomen below the area of obstruction. All right? And why were the other answers wrong? Well, pyloric stenosis, it's not going to be present at birth, so they're never going to give you something immediately at birth and expect it to be pyloric stenosis. That typically occurs within the first month or 5 months of life, and they would give you a scenario of a baby that's like they would do the firstborn male couple months of age with that, and it wouldn't be bilious emesis because the obstruction's right at the pylorus, so it's before the bile comes in the second portion of the duodenum. A midgut volvulus, why wouldn't it be that? Well, that's usually not present at birth either. So, but always, always, always suspect that if any baby initially did great with feeds and then suddenly stopped tolerating feeds and has sudden onset of bilious vomiting within the first few days or months of life. Hirschsprung's disease, why isn't it that? Well, bilious emesis, marked abdominal distension and delayed meconium passage are more common presentations. So the baby typically with Hirschsprung's would have a very distended belly. They wouldn't spit up and then have like a flat abdomen, and there would be air all the way through on the X-ray. Ileal duplications, that is the number one location for duplications in the GI tract, but that typically is a childhood or adulthood presentation. All right, GI malformations for 500. A 2-week-old male is brought to the emergency room with bilious emesis and abdominal distension. He has been irritable and had poor oral intake for 12 hours. No stool passage was reported today, but he previously had been stooling normally. What's the most likely diagnosis? Is it A, a midgut volvulus, B, Hirschsprung's, C, sepsis, D, milk protein allergy, or E, a viral gastro? Guys are good. So yeah, this is the one diagnosis you do not want to miss. And so oftentimes the scenario will be, unfortunately, it'll be the middle of, in life, it's the middle of December, February, it's right in the middle of rotavirus season, and everybody, all the other family members have vomiting, diarrhea, but you always have to listen to the story, look at the baby, and this is the thing to be feared. So a baby with intestinal malrotation and midgut volvulus will come in with bilious emesis, because the obstruction is distal to that ampulla vater. And you know that when developing in utero, our intestines around 9-10 weeks gestation are forming too quickly to be held within the abdominal cavity. So they actually have to leave the abdominal cavity, hang out in the umbilical cord for a few weeks, and then they're supposed to come in, turn 270 degrees counterclockwise, and come in perfectly for a landing and become fixed. And it's a miracle that it occurs right in any of us. But in little ones that it doesn't, and there's a wobble or an axis issue, if the volvulus occurs, you can get ischemia of the entire small gut, and you can't live without your small bowel. We do have a small bowel transplant program at the clinic, but boy, you want to, it's a very serious undertaking if you lose your small bowel. So volvulus, remember, it can occur at any age. Typically, it's more common in infancy, so less than 12 months of age. So, and on the board, they'll be fair about this too. So it will be someone within the first 12 months of life. Usually, it'll be probably a couple months of life. And remember, it's surgical intervention has to be done quickly to preserve as much of that small intestine as possible. All right, so GI malformations for 1,000. 1 day old, delivered at term to a mother with insulin-dependent diabetes mellitus, develops abdominal distension and bilious emesis. No meconium passage has occurred. On exam, the x-ray is markedly distended but non-tender. Rectal exam is normal. What is the most likely diagnosis? Is it intestinal malrotation with a midgut volvulus, hypoplastic left colon syndrome, meconium ileus, duodenal atresia, or Hirschsprung's disease? So 1 day old. Infant of a diabetic mother. Good job. So yeah, so this is what's known as the hypoplastic left colon syndrome. So it's more common in little ones born to mothers with diabetes. The incidence of congenital malformations in these babies is 3 to 8-fold compared to other pregnancies. GI-wise, in our field, small hypoplastic left colon syndrome is the most common occurrence. It's also called functional immaturity of the colon. But they also can have the duodenal or anorectal atresias. And then I've listed other cardiac, neurologic, and renal abnormalities in babies. But again, remember, they're giving you the information in the question as a hint or a clue. And again, just look at the age of the baby. The rectal exam being normal just told you it's unlikely to be Hirschsprung's disease, because those are the kiddos, if we suspect it, and we're just reading through the chart, we send the medical students in to do the rectal, because with Hirschsprung's, you put your finger in, and upon withdraw, it's like Mount Vesuvius with stool. So it wouldn't be a normal rectal exam with Hirschsprung's disease, is why that one was wrong. All right, so name that bleed. Let's move on for 100. An otherwise healthy 7-day-old male is brought to your office for evaluation of bloody stools. He was delivered at home without complication and has been exclusively breastfed. He has not previously been examined by a physician. On exam, he's mildly tachycardic, has some bluish areas over his lower extremities and buttocks, and his stool is strongly heme positive, but the exam is otherwise normal. So what do you think the most likely diagnosis is? Is it A, sepsis, B, salmonella, C, hemorrhagic disease of the newborn, D, physical abuse, or E, a colonic polyp? Good job. So yeah, this is pretty classic. And like I said, it's representative of how you're going to be quizzed on the board. So typically hemorrhagic disease of the newborn develops between day of life number 2 and 7, secondary to vitamin K deficiency. And in this case, it was a home delivery. They forgot to give the vitamin K as the scenario. But risk factors include breastfeeding, because breast milk is a poor source of vitamin K, maternal meds. So some questions may have the patient's mother on an anticonvulsant. So they'll give you her med list, or say she has a seizure disorder and is on medical therapy, and you have to know that phenytoin and phenobarb are associated with bleeding in the baby. Sites of hemorrhage are important. So in the GI tract, you're going to get bloody diarrhea, but you can also have nasopharyngeal bleeds or mucous membrane bleeds, even intracranial bleeds. The circumcision, it may be a male with prolonged bleeding associated with the circumcision, or it can be cutaneous, like in this patient with bleeding underneath subcutaneous bleeding or bruising. Hemorrhagic disease in newborn is prevented with a vitamin K at birth, and treatment, if there is ongoing bleeding, is a slow infusion of vitamin K or FFP, whole blood, for a preterm infant if they have any liver disease associated. All right, name that bleed for 500. A 14-year-old male presents with a 6-month history of intermittent low-grade fevers and right lower quadrant pain. I'm going to cry if you guys missed this. But his appetite is decreased as pain worsens with eating. Weight and height have decreased from the 50th percentile to below the 10th at this point over the past 2 years. So you look at the growth chart and it's been just this gradual decline. On exam, the patient has mild right lower quadrant pain and fullness, no peritoneal signs, fortunately. Stool is hemocult positive. So at that point, you're reading the question like, oh, I know what the patient has, and then they don't ask that question. So of the following, the most appropriate initial diagnostic test would be, and you look at these, you look at the questions and you're like, well, they wouldn't necessarily be wrong, but what you're looking for is what is the most likely to be diagnostic test? Is it an abdominal CT to rule out a perforated appendix? Is it a barium enema? Is it an upper GI small bowel follow-through, an abdominal ultrasound, or a stool culture? So what would be diagnostic potentially? So good job, yeah. And the question, the answers may be, the options may be CT enterography or MR enterography or endoscopy would also be in the C category as appropriate. So you know they didn't have a perforated appendix because they're saying no rebound or guarding. Barium enema is not really a diagnostic test, nor is the ultrasound. And stool cultures, this has been going on for a long time. And SSYC, CDIP, those things, the bacterial infections typically don't last more than a few weeks without being burned out. So yeah, you're looking for a diagnostic test that gives you a definitive or semi-definitive answer, so good job. All right, name that bleed for 1,000. A 2-year-old male is brought to the emergency room following painless passage of a large maroon, or they may say brick-colored stool. Patient is mildly tachycardic on exam with heme-positive stool and tarry stool in the vault because you did a rectal exam. Good job. Hemoglobin is 6.8 grams per deciliter, so they literally lost about half their blood volume, and that is classic for this condition. Of the following, the most likely diagnosis is what? So rapid blood loss in a 2-year-old. Is it IBD, peptic ulcer disease, a colonic polyp, a Meckel's diverticulum, or bleeding disorder? Good job. Almost all of you got that right. That is classic for Meckel's diverticulum. So that is a remnant of the omphalomesenteric duct. It presents with painless bleeding, or it can just be intussusception, so horribly painful obstructive symptoms. But most commonly on a board and in life, it's going to be a massive GI bleed where you drop half of your blood volume, and it's going to be a dark burgundy or a brick-colored stool, not like bright red. Rule of twos apply, so we always have to commit these to memory. So it occurs in 2% of the population. Typically, the omphalomesenteric duct remnant occurs within 2 feet of the ileocecal valve. So when a surgeon goes in to look for it, they run the bowel at least they'll go like 4 feet up to make sure that they didn't miss it. Most common age to be symptomatic is 2 years of age, but it can literally occur in anybody. So my husband's an adult gastroenterologist, and he's diagnosed a 75-year-old with a Meckel's diverticulum from a bleed before. So just know that any of us in the room, 2%, there's probably over 100 people here, so there's probably a couple people in the room that may have it, not know it. Happy thought of the morning. And then male to female, so boys, it's more likely you, it's not us girls. Male to female ratio is 2 to 1. A majority of symptomatic lesions are lined with gastric mucosa that secretes acid and ulcerates the adjacent ileomucosa. So it's not the Meckel's diverticulum that bleeds. It's just the fact that the ones that do become symptomatic are lined with gastric tissue that secretes gastric acid that ulcerates the surrounding ileal tissue, and it nails an ileal artery is what's bleeding. It's an arterial bleed. A majority of symptomatic lesions, like I said, will be within 2 feet. A surgeon will find them. They'll run the bowel looking for them. You can up the chances of your diagnostic test before you send a surgeon in by giving either, and it's better IV than oral, but an H2 blocker or a PPI. It increases the sensitivity of your Meckel scan. So even if it's given within the hour of the test. And then, of course, surgery is the cure. But they may give you the whole scenario and then ask you what test is the best test, and you're going to answer a Meckel scan. I don't think they're as progressive as to say give a medication before it, but just know in life, give an IVH2 blocker or PPI to increase your chance of finding it. All right, when the movement needs improvement for 100, a 20-month-old infant is brought to your office with a 3-month history of 1 to 4 loose, non-bloody stools per day. Undigested food particles are often seen in this stool, and the mother goes into, I see carrots, and I see peas, and I see, oftentimes they'll have a list of every food item ingested and what they're seeing in these stools. You take the rest of the history, there's no history of fever, abdominal pain, there's no nighttime stooling. Growth and development and physical examination are normal when you look at the child and review all the growth parameters. So what do you think the most likely diagnosis is? Is it A, chronic nonspecific diarrhea? B, inflammatory bowel disease, C, lactose intolerance, D, giardiasis, or E, a cow milk protein allergy? Kid is 20 months old, looks like a rose. Good job. So the old terminology for this was toddler's diarrhea. I term this death by sippy cup, because I think as parents we've gone from, it's socially acceptable to use a bottle up to 12 months of age, and then after that parents change the bottle into the sippy cup and think that that's the socially acceptable form, and we're all guilty of it because it protects our carpets and But the problem is people keep filling up the sippy cups, and it doesn't matter if you fill it up with even water. The little one's colon is just not able to absorb it. So if I had each of you in the room right now drink 2 liters of whatever water or coffee out there to stay awake, we would have to just urinate. But if you gave a little one this age 2 liters of something, their colon can't absorb like ours does, and so even 6 ounces over like their maintenance can sometimes result in just diarrhea. But toddler's diarrhea, or irritable colon of infancy, it's termed. The newer term is the chronic nonspecific diarrhea of infancy, which shows up on the boards. It is the #1 cause of chronic diarrhea of childhood. Typically presents between 6 and 20 months of age, so it's that sippy cup range. The patient will come in with a history of stooling 2 to 10 times per day. It's never bloody. There may be some mucus. The mother will always tell you about the undigested food that's there. And usually the interesting thing is there's no stooling at night, so while they're asleep, they're not stooling. Common dietary history is that of low-fat intake, possibly increased carbs, apple or other juices. Excessive fluid intake is usually the cause, though. And the treatment is just simple increase in dietary fat, decrease the carbs and total fluid. So literally calculate out, or the better thing is just to tell them, make them learn how to drink out of a cup and drink to thirst, not use it as though it's a bottle or a comfort item. And it spontaneously goes away in 90% of kiddos by about 40 months of age when the colon's mature. Right, so why were the other answers wrong? So IBD, remember I told you it shows up in our age range within the 2nd decade of life. So the kid's not going to be 20 months old. They're going to be 10 to 20 years of age. They're not going to be sneaky with the board because it's an atypical presentation. So IBD, again, is blood in the stool, abdominal pain, growth failure, extraintestinal manifestations, which this little one had none of. Lactose intolerance is uncommon in kids under 5. Usually you start thinking of lactose intolerance at school age. Giardia, that's an infection from fecal contact, can occur at child care centers. It's usually through contaminated water. I basically, if anyone's jumped in Lake Erie, I start thinking that. If they jump in a pond, a lake, a stream. But symptoms associated with that also include fever, vomiting, fatigue, abdominal distension, weight loss. Diagnosis is made through stool microscopy or analysis for the antigen, and the treatment is oral metronidazole, tinidazole, or nitazoxide. Calmic protein allergy typically presents within the first few months of life. It's, with diarrhea, poor weight gain, irritability, and oftentimes vomiting and blood in the stool. So again, it wouldn't be showing up all of a sudden at almost 2 years of age. All right, when the movement needs improvement for 200, in the United States, what is the most common cause of rectal prolapse? So is it chronic diarrhea, chronic constipation, malnutrition, anorectal malformations, or parasites? So this is one of those where you use your test-taking skills and say, just what's the most common thing of all those that... Correct. So I told you like what I do after 5 p.m., but if you 25% of the time, what is Dr. Mahajan doing? It's dealing with constipation, says a gastroenterologist. So that becomes the most common cause of rectal prolapse, just based on sheer numbers. Either diarrhea or constipation can result in rectal prolapse. It also can be associated with cystic fibrosis or other malabsorptive states. And Trichuris trichuria, if they ask, is the most common. The dog whipworm is the most common parasitic infection. But just by numbers, chronic constipation is the right answer. All right, when the movement needs improvement for 1,000, a 3-month-old is brought for evaluation of constipation. She is passing small, hard stools every 4 to 5 days, and the mother's concerned with the infant's irritability and straining prior to and during stooling. It's one of those scenarios where you listen to the story and you're going, and the Oscar goes to this little one for the energy put into the stooling attempt. The mother reports that meconium was passed within the first 24 hours of life, and the newborn screen was normal. Current diet consists of 30 ounces per day of cow milk-based formula, and the physical examination, including the rectal exam, is completely normal. So of the following, what's the most appropriate nutritional management of this patient? Would you say, well, let's change to a soy formula? Would you say, let's change to a formula with a lower iron content? Would you say, let's start rice cereal? Would you change to an elemental formula? Or would you give pear juice in addition to the current formula? What would be your recommendation? correct. Good job. So the soy, so if you want to constipate somebody in life, I always say give them soy or give them rice. So the A and C would have clogged them a little bit worse. So that wouldn't have helped. There's no indication for low iron containing formulas on the market. People used to use those frequently, and babies became more and more iron deficient, so that would not be helpful. And then elemental formulas, while they would likely help, are just expensive. So they're also looking at you on the board for cost effectiveness. So the best thing that you could do if the baby has a little bit of what's called infantile dyschezia is the name of this, is to give a carbohydrate that's poorly absorbed. So apple, prune, and pear juice. The baby will have difficulty absorbing all the carbohydrates in there. They're natural laxatives. But I always just make sure that I tell them it has to be a pasteurized form of apple, prune, or pear juice. And then a few ounces a day in addition to the regular formula, and see them back. All right, so GI potpourri for 100. A 15-year-old female is followed in your office for recurrent headaches, for which you prescribed ibuprofen. The patient returns with severe epigastric pain and melanic stool. And for the GI fellows in the room, it's not melanotic stool, it's melanic stool. Melanotic is a dermatologic term. So a lot of people get used to saying that melanic stool is the proper GI term for when it's black and tarry and an upper GI bleed. So patient comes in, epigastric pain, melanic stool. Your timely and efficient gastroenterologist performs an upper endoscopy and finds a large gastric ulcer. What is the most likely mechanism by which the ibuprofen caused this ulcer? Is it A, decreased pepsinogen production, B, increased gastrin production, C, stimulation of H. pylori overgrowth, D, inhibition of prostaglandin synthesis, or E, gastric mast cell degranulation with histamine release? And shockingly, this is a pediatric general board question. Something like it. You have to know this. And you guys do. Good job. So yeah. So your NSAIDs damage the GI tract by inhibiting cyclooxygenase. So that is an enzyme essential for the good guy production, for prostaglandin production. So they can cause ulceration, bleeding, stricture formation, anywhere from like your stomach all the way through to the colon. So you can get a webbing in the small intestine as a result too. To a lesser degree, you can get local injury and stimulate the production of inflammatory mediators and oxygen radicals. So yeah, you've got it. The prostaglandins are the good guys. They increase bicarb mucus production, stabilize cell membranes throughout the GI tract, increase GI mucosal blood flow, and decrease your gastric acid production. So good job. All right, GI potpourri for 200. A disgruntled 16-year-old male comes to your office and states that since you referred him for treatment of reflux 6 months ago to the timely and efficient gastroenterologist featured in the previous question, he's had bilateral breast enlargement. What medication did the timely and efficient gastroenterologist most likely prescribe? Did they prescribe omeprazole, lansoprazole, metoclopramide, ranitidine, or famotidine? So looking for mechanisms of action. Was it a PPI, an H2 blocker, or a prokinetic? Good job. So yeah, so metoclopramide C is the answer. So metoclopramide can result in not only a prokinetic promotility effect, it can also cause extrapyramidal side effects. So it can stimulate prolactin production and increase breast size in males and females. It's often used as a medication that helps produce increased amounts of milk when women are struggling with regards to milk production, better than fenugreek actually works. But not too many people, due to the risk of dystonic reactions, are comfortable anymore prescribing it to women. But female patients will not, like teenage girls, will never come back to you and tell you what the medicine did because they like their new bra size. Boys, however, will not appreciate their new bra size, and they will come back to you if you prescribe it. So, all right, so GI potpourri for 1,000. And this one's Dr. Hubert's talked to you a little earlier about. 16-year-old female presents with a several-year history of intermittent scleral icterus, and it's noted most often during or after a cold or flu-like illness. May also report that it occurs during menses. Otherwise, she's healthy, on no medications, doesn't drink. Physical examination, she has an indirect bili of 4 milligrams per deciliter, direct bili of 0.3, and aminotransferases, albumin, PT, all normal. Of the following, what's the most likely diagnosis in this patient? Is it A, Gilbert's? Is it B, EBV infection? C, chronic viral hepatitis? D, hepatitis A? Or is it a Roeder's syndrome? Good job. So it's a classic scenario that you'll get with Gilbert's. So that's a hereditary form of an indirect mild hyperbilirubinemia. It can be inherited, autosomal recessive or dominant. Typically manifests after puberty with mild indirect hyperbili during fasting, illness, or menses. Results from abnormal expression of the enzyme UDP glucuronal transferase. And there's no negative implications on longevity. It may just be a lab abnormality that you pick up. And we don't typically ask, we don't order labs to definitively diagnose it, but if in practice you want to say, oh, is that what it really is or not, you have the patient do a lab after a meal, and then you have them repeat their bilirubin when fasting. And typically when they're fasting, it will be double of what it is after a well-fed, in a well-fed state. So that's how you can clinically diagnose it. And they may have a history, an increased likelihood of a history of prolonged hyperbilirubinemia in the newborn period. May have been one of those babies with the Billy blanket. Again, just reassurance, no need for therapy. So good job, guys. If you scored less than 500 on the GI portion, I would exit immediately and just go study GI for the duration until the test. And if you did more than that, you look like $1 million. And good luck with everything. Just study, 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 study.